Okay, let's go ahead and get started. I've got 4 minutes after. Welcome. My name is Scott Suko, and I'm the Executive Director of the Liver Coalition of San Diego, and we are the convener of the Eliminate Hepatitis C San Diego County Initiative. Our initiative is a public-private partnership between the County of San Diego and community stakeholders. Planning process that started our elimination initiative started in November of 2018, which resulted in a recommendations report the following year, in that December, and then followed that with the approval of our implementation plan by the Board of Supervisors on July 13th, 2021. On January 1st of this year, the County of San Diego contracted and provided the funding to the Liver Coalition of San Diego to serve as the convener of this partnership. Additional funding has been provided by unrestricted educational grants to the Liver Coalition of San Diego as serving as the convener of the partnership by AbbVie and Gilead Sciences. This is our second learning exchange, and we've gotten the topic really from conversations that we've had with many of you. So today's topic is addressing hepatitis C amongst the homeless through field or street medicine. And we've got a great program put together. And before I introduce our moderator, I'd like to just say that as we take a look at this and this population that we're talking about, trust is really at the cornerstone of how to most effectively to treat and interact and engage with a population that really utilizes services very different than possibly you and I do. And I wanted to just cite something we heard recently from the San Diego Regional Task Force on the Homeless. In general, we say outreach requires persistent and constant engagement. Due to the lack of trust and trauma, for many, it may take 100 of touches before they are willing to engage as a trusting relationship has been built. For others, they may be readily eager to engage. So as we approach field medicine, it's just not a matter of providing services. It's really about the partnerships and trust that are going to have to be in place. Some providers will have that trust, and that's great. Other providers will have to partner with an organization that has that trust so that they all get the same results. So I'm very excited for this conversation to take place. The timing is very relevant in our community. Last year, Governor Newsom vetoed a bill that was approved by our state Senate and Assembly, and he cited the CalAIM initiative for California that really takes a look at our population and says, let's look at enhanced care management and how we can provide street medicine through that. That is an option. We'll hear about that a little bit later. And as this goes, as a payment source, it's not a done deal yet. So until it's a done deal, patient advocates need to keep the awareness up. And the best way to increase awareness is to have people have a greater understanding of what do we mean and what's the potential of street and field medicine. So to get us started, I want to introduce our moderator, Andrea Tamata, who is with the County of San Diego and serves as our vice chair of this initiative. And Andrea has a wealth of experience and has just been diving into all sorts of the elimination initiatives. And so with that, I introduce Andrea.
Thank you, Scott, for that introduction. So I'll be serving as your moderator today, and I wanted to go over a few housekeeping items before we begin. So the first thing I want to mention is that to please mute your microphones right now so that we don't have disturbances during the presentation. Also, please, we're going to be having everyone turn on your cameras for audience engagement. We will take a screenshot at the beginning, excuse me, as a group for social media and other communications. And if you do not want to take a picture, please turn off your camera. Also, please introduce yourself in the chat box with your name, the organization, and the city and state in which you represent. Put your questions into the chat field at any time. We have a moderator who will be working in the chat. His name's Ryan Clary. We will also have time after the presentations for questions and answers and discussion. Although we do have a full agenda, we may not be able to get to all the questions, but we will follow up and send answers via email. Also, recording of the learning exchange will be made available on the Liver Coalition of San Diego's website. Okay, so I think we have all that. And then Scott, I'm not sure if you're able to, would you like to go ahead and do the screenshot right now?
Yes. So if people make sure they turn on their cameras, I'll go through the orientation and take our screenshots.
Are we going to get a cue?
Yeah.
Okay.
I see some of them are still turning on. So the first page is good. If you keep turning on the cameras, that will be great. And I'm taking them right now. So if you look at the camera, this would be great. I'm on the second page. And the third. Great. It's all yours, Andrea.
Fantastic. And I don't know if we're able to, maybe we can mute the bell as people enter so that we're not disturbing our speakers. Okay, so I will go ahead and introduce our first speaker. He's representing the Hawaii experience, Thaddeus Pham. He, him, his pronouns are he and him, is the viral hepatitis prevention coordinator for the Hawaii Department of Health. He is also co-director of the Hep Free Hawaii alongside Heather Lusk. Heather is the executive director of Hawaii Health and Harm Reduction Center. Welcome, and the floor is yours.
Fantastic. Aloha, everyone, and thanks for joining us today, and thanks for inviting us to this space. So I'm going to go ahead and share screen. If you could just let me know when you see it full screen. Yes?
Yes, we see it.
Fantastic. So I'm today here joined by Heather Lusk. So I'll introduce myself again really quickly. Thaddeus Pham, he, him. I am the viral hepatitis prevention coordinator with the Hawaii Department of Health and co-director of Hep Free Hawaii. And I'll have Heather introduce herself.
Hi, aloha, everybody. As Thaddeus said, I'm Heather Lusk. I'm lucky enough to be Thaddeus's partner in justice as co-founder and co-director of Hep Free Hawaii. And then the Hawaii Health and Harm Reduction Center is the fiscal sponsor of Hep Free Hawaii. And we have the street medicine program we'll be talking about today. Thank you so much for having us.
Awesome. Thanks, Heather. And as you folks probably already tell, Heather and I talk fast and voluminously. So feel free to put comments and questions in the chat. I know there's a pretty packed agenda today. So what we're going to share with you a little bit is just a taste of what we do around street medicine related to hepatitis and our work with Hep Free 2030, which is our elimination strategy for Hawaii. So first, some local context for Hawaii, and also shout out to all of you folks in San Diego. I used to live in North County, in Solana Beach. I used to work in different parts of the county. So, but in Hawaii, what's happening? So we don't have great surveillance data, but we do know is that Hep B and Hep C account for most of the liver cancer cases, according to our transplant center, and that we have one of the highest rates of liver cancer, both in terms of incidence and mortality across the US. We actually used to be #1, but I think we're now around #7 or 8, which hopefully means we're doing a great job, or sadly, other states are seeing way more burden of hepatitis related and other issues around liver cancer. These are some of the communities that we really just uplift and note, not to stigmatize, but really to share, show that these are communities that we should be working with and alongside. So of course, you folks are fully aware of hepatitis A and among the houseless communities, especially given what you folks went through a few years ago. Our sexual and gender minority communities, or commonly known as LGBTQIA+, of course, are affected by viral hepatitis. For Hawaii, we have actually a very diverse demographic, especially among Asian and Pacific Islanders and among people who are born outside of the US. So that is really a community that we try to work with, especially for hepatitis B. And then of course, for Hep C, we have our drug using community and our folks who are formerly or currently incarcerated. So a lot of folks and a lot of communities impacted in Hawaii. And we just really always want to make sure that we address all the different communities, especially our folks who are more vulnerable. So those are, of course, our houseless and people who use drugs. So I'm going to turn it over to Heather to give you a little bit of context in terms of what we're trying to do to support these communities to eliminate hepatitis. So Heather, go ahead.
Thanks so much, Thaddeus, and thank you again, everybody. And forgive me, I'm getting over an illness. But like many communities, we have a roadmap to make our islands HEP-free. Next slide, Thaddeus. And we've grounded our HEP-free 2030 plan in a mission and vision, like I'm sure you all in many jurisdictions have. As you see here, we're really going beyond just, we were, I believe, one of the first areas to have HEP A, B, and C as part of our elimination strategy. Because of our small islands and also because of the interconnectedness. And as you see, like many communities, we are envisioning our community and our islands to be free of hepatitis and other liver disease. And as Thaddeus said, we really do try to ground our work in people with lived experience, and that's going to is really the foundation of our street medicine program. Next slide. We have 4 values that we ground our work in and start every hepatitis meeting with, which is harm reduction, social justice, intersectionality, and aloha. Aloha in Hawaii is much more than hello or goodbye. It also is love, and really the spirit within which we do the work that we do and do the other 3, trying to support social justice, and again, trying to intersect hepatitis at any available opportunity and using any open door, whether we pound down the door or partner with our other stakeholders. Next slide, Thaddeus. So our 5 major areas, as you see here, are awareness, education, access, advocacy, equity, and everything, and data for decision making. We're going to talk a bit more about the access to services, about how we're bringing hepatitis services to the street, whether that's our immunizations, testing, linkage to care. While we haven't brought treatment yet, we are getting ready to take hepatitis C treatment out into the community. Next slide. So these are our priorities in our access to service areas and where our street medicine efforts have interplaced. And right now, at least through the Hawaii Health and Harm Reduction Center, we are able to offer both testing and immunizations in our street medicine program. And now that we have a FibroScan that is a portable FibroScan, we are working on logistics to take that into our medical mobile unit. And as you see here, we're also working with, like many jurisdictions, to try to reduce the barriers to treatment. And happy to say we had a very successful meeting with our Medicaid office and are hopeful, fingers crossed, right, Thaddeus, that we'll be seeing a memo come out from our Medicaid office in the coming weeks, lowering barriers to hepatitis C treatment. Next slide. But I know we're here to talk more specifically about our some of our successes and challenges in our street medicine program. So I'd like to introduce you to Ka'alave Pono, which is our medical mobile unit. You see there in the middle, that literally translates in Hawaiian to the vehicle that delivers wellness. This is really an outcrop of our wound care and hepatitis testing program that is run by Dr. Christina Wang. You see her treating wounds on the side. So prior to having our medical mobile unit, and sometimes still, our street medicine team is on foot. And what we found when talking to people, by the way, we run the statewide syringe exchange program here in Hawaii and exchanged 1.3 million syringes last year. And so we'd already been integrating hepatitis efforts into our syringe program. But what we found is that oftentimes when people were coming to get syringes or naloxone or other supplies, they didn't always have the time to be able to do the rapid test or get immunized. And so needs assessment showed that wound care was a very big need among the houseless and people who use drugs in our community. And so why Dr. Wang is providing wound care, for example, right there with that person on feet, there is actually a tester right next to them if they're interested doing the hepatitis C testing right there on the streets. So you also see Mono, one of our outreach workers who also drives our medical mobile unit. He's doing a rapid test for hepatitis right there. But so we're doing it not only through the medical mobile unit and getting that around the island, but really just taking it out every time we talk story with somebody, whether it's wound care. We also do homeless outreach and assessments to get people into housing. Anytime somebody has an interest, we then also say, well, would you be interested in a hepatitis test? So that we can really utilize the time and also know that people are already getting one need met. It's a great opportunity to integrate the other. Next slide, please, Thaddeus. In addition to doing these street medicine projects, we are doing a lot of community events. This is this actually is our PrEP, pre-exposure prophylaxis for HIV coordinator, Cullen. He's also cross-trained in hepatitis. So we do, whether it's pool parties or other events that may target the LGBT community, and then again integrate hepatitis. Now we're integrating monkeypox vaccinations as well. And again, there's our Dr. Wayne going into the street to do these services. So we've really found that by integrating services, that intersectionality part of our values, that people have been much more open to accessing hepatitis testing, immunizations, because again, we're meeting a primary need, whether it is wounds, food, housing services, and kind of adding this on where we weren't as successful when we were just purely offering the hepatitis service. Next slide, please, Thaddeus. I think I turn it back over to you, but just wanted to note that our biggest challenge, and one thing that we know that you all are probably looking at as well, is that right now street medicine is not reimbursable. So because there's not a place code, it's not a person's home, it's not a clinic, all the services that we currently do on the street, we have to subsidize through grants, because I'm not able to bill for insurance the same way I am if they walk in to the clinic. So Thaddeus, I'm going to turn over to you to talk a little bit about the work that Thaddeus has been spearheading with the Street Medicine Institute and other key partners to try to get both nationally and locally the ability to get reimbursement for street medicine, specifically hepatitis services. Thanks, Thaddeus.
Awesome. Thanks, Heather. And folks, I know this is quick, but you will get slides, I believe, afterwards. So as Heather was saying, it's not only just us, but when we started to have this discussion with our partners, both nationally and locally, many people are finding that street medicine is such a core service for what they do, but they're not being reimbursed for it. So it can't be really sustainable unless they kind of scramble money. And I'm sure many of you have seen this as well, who do street medicine or similar work with these communities. So what we saw, as you can see there, is it wasn't being reimbursed. There is no taxonomy code for street medicine, nor is there a CMS point of care code for field or street. So these are not mobile medical units, right? But really, literally outside of four walls, providing services. So a lot of folks will kind of try to work around it by kind of using field codes of street medicine or homeless shelters, but really just how do we increase the billable services in terms of what's actually happening. So we did reach out to the Street Medicine Institute at USC, that's Brett Feldman, as you can see there, who also collected data from a bunch of different street medicine clinics across the nation to show that this is actually an issue for many of them, or for most of them, I would say. And what we did with them is worked with our partners. If you're familiar with NASTAD, that's one of our national partners who do advocacy on HIV, hepatitis, racial equity, and harm reduction, as well as the Hepatitis B Foundation, which is also a global partner. And we drafted a letter to CMS. It was a sign-in letter. I believe there were 80 plus organizational sign-ons that was sent in early 2022 to CMS. Unfortunately, CMS was going through a reorg at that time, so we're still pending their response in terms of adding that field code, but we're continuing to move forward locally. So I'll note that thanks to our local partners, especially our rural folks, our federally qualified health centers on Hawaii Island and other islands, we are starting to discuss that locally with our Medicaid, and also trying to push through our other partners, including our housing coalitions and things like that. Finally, I do want to note that this issue was brought up during the White House convening. As folks are probably aware, the White House is seeking to make a Hep C elimination plan nationally and fund it. So exciting, but one of the components that folks brought up strongly was reimbursable street medicine, because we know that a lot of the folks who have hepatitis C are often hard to reach. And if we can provide services, as Heather showed, where they are at, it will vastly improve health outcomes. So that's about it for us. I'm sure you folks have a lot more questions and comments, but we're going to turn it back to our moderators. So Andrea, I think I'll turn it back to you for the other speakers. Thanks so much for your time today, everybody.
Thank you so much for that. So go ahead and we will introduce representation for the San Diego experience for the part 1, and that would be Dr. Jeffrey Norris, Chief Medical Officer of Father Joe's. And the floor is yours.
Sure. Let me know if you can hear me okay without any.
We can hear you.
Okay, perfect. Well, it's good to see many of you all. I know many of you all. I can see cameras up. I can see Christian and George and others, not calling out just you all. I know a few others of you all, just the faces I quickly recognize. So I'm excited to be, oh, there's Jorge on camera. I know Jorge too. Excited to see, oh, and we're getting more. Jennifer, all the people I know are popping on. I love this. This is great. All my friends are going on camera. I really appreciate the opportunity to come speak to you all about street medicine here in California, some of the legislative changes, and then I'll talk a little bit about our program in particular. I don't have any slides, so I'm just going to do this informally, and I'm happy to take questions, comments, etc. As we go or at the end. Dovetailing with what the folks from Hawaii were talking about, there's actually some really interesting and exciting things that are happening here in California around reimbursement that are very different than other parts of the country. And Jennifer is actually referencing some of that in the chat right now. So let me give you some of the legislative background, kind of the story, the backdrop of what's happened over the last actually year, almost exactly a year at this point. Last year, Senator Kamlager, State Senator Kamlager, had put forth AB 369 as a bill that would make street medicine, I jokingly say, undeniably billable through Medi-Cal. Yeah, I know, George, you'd get a kick out of that one. Nice pun with billability. And that was because historically, folks, especially FQHCs and primary care providers, did not feel comfortable billing for street medicine services. It was unclear whether or not street medicine was billable under fee-for-service here in the state of California to Medi-Cal. There wasn't any clear guidance. There was no documents that said this was billable, nothing in the billing guide for Medi-Cal, et cetera. So folks really felt uncomfortable billing for those services. The governor vetoed that bill, but he didn't veto it because he didn't believe in street medicine, which was really kind of a big pivot and exciting movement. And we all know that a lot has been changing with Medi-Cal seismically over the last 4 to 5 years with CalAIM. And this was, I think, just another example of differences in the way this administration sees DHCS and Medi-Cal services. What he said in his veto letter is that he didn't think there needed to be a bill passed by the legislature in order to make this a billable service. He believed that DHCS could work this out among the MCOs, among themselves, the state, and among providers out in the state of California. So what the letter actually said is DHCS convene a group of stakeholders and figure this out. This should be doable. Like, you just need to figure out how to make this happen. And DHCS actually asked, there's a reference from the folks who just presented to Brett Feldman at USC, who runs the street medicine program up there and is a good friend of mine. They, because he has grant funding from CHCF to kind of help gel the street medicine providers across the entire state, DHCS asked him to bring together a group of providers from across the state, provider representation, as well as MCOs, and then state representatives to convene a work group, an ad hoc work group to figure this out, figure out what the next steps would be in all of this. Very rapidly, actually, it was the second meeting, and I was a part of all of these meetings along the way. The second meeting, and I will quote J.C. Cooper because I was kind of flabbergasted by this. J.C. Cooper basically said it's a myth that street medicine is not a billable service. This is a billable service. So that was said in the second meeting. I, of course, and others said, can we get that in writing? You always want things in writing, especially when it comes to DHCS. I'm sure many of us have been through that before. And they subsequently put out in December, and I'll put it into the chat right now, if the link, it's going to do my safe links here. I'm going to have to put the links in later, unfortunately, because it's coming through my firewall, so it's a weird link. But they subsequently came out with a clarification document in December, making it clear that street medicine was billable as fee for service, and that street medicine teams could also do presumptive eligibility for Medi-Cal, which was a real clear shift and making things much more black and white. They did acknowledge the place of service code issue that was mentioned in the prior presentation. There still is no clear place of service code for street medicine at a national level, but they gave clear guidance to use place of service codes 15 and 16 for these services. Again, nationally, I think this is a hole that has to be fixed. We need to create a place of service code that can be used across the entire country. But right now that doesn't quite exist. So they said use these other codes in the meantime. The conversations with JC Cooper and her team continued. I think we had a total of 5 or 6 meetings, I want to say, over time. And the conversation started to really shift to how do MCOs become a part of this effort, and what role do the health plans play in both supporting structurally street medicine teams, but then also reimbursement of street medicine teams. And that resulted in a draft all plan letter that was put out in August timeframe, and feedback was asked to be received by September 1st. So some of you all might remember that request for feedback. I'll put the link in later since my links are not working properly right now, or maybe I can multitask. Hold on. Give me 5 seconds and I'll put the links in right now. Got to open them in my browser. All right, so the first link is the clarification on billing, and the second link is the draft all plan letter, which to my knowledge has still not been issued by DHCS. So I think they're still looking at feedback and making further potential changes to that. But if you look through the all plan letter, it's really talking about how do we create more of a system of care under the MCOs here in California that is inclusive of street medicine and really recognizes that street medicine is foundational to an effective healthcare system for people experiencing homelessness. This is seismic. This is a really, really big shift in the way we all look at healthcare and the way the state is looking at healthcare. We've gone from this gray space of, is this billable? Is it something we can do? Can we get paid to? Yes, you can. And we need to figure out how to give scaffolding and legs to what we do around street medicine in California. So that is seismic and huge. And that's where we currently are at this point. I did ask for the FQHCs out there, I did ask a very direct question about fee for service. I said fee for service for FQHCs means the PPS rate. For those who don't know what I'm talking about, you can Google PPS rate and FQHC and read all about it. For those who know what I'm talking about, this is the main way we get paid. And the answer to that question on a direct email to one of the high-ups in DHCS is yes, that means you can bill your PPS rate. There is no question of that. That is not in the clarification of billing. It would be great if that was placed there. But I have it in writing, in email from DHCS that means we can bill our PPS rate. So that's where we currently stand. That's where we've come to in California related to bringing in funding. I do want to make a comment about billability and the revenue that's generated that I think is really important to highlight. And that's that even with billing for these services, even with the PPS rate, these clinics often are lower visit volume models than a traditional brick and mortar clinic. You just simply can't drive that much volume through a street medicine clinic consistently. Sometimes you get a lot of folks, you go see a lot of folks really quickly, but sometimes you don't, and often you don't. And the focus is not on volume as much as it is on building relationships. And I'm sure the folks in Hawaii can kind of attest to that, and they were speaking to that. Of course, FQHCs are still paid per visit, so that is a financial reality that we all face. Brett Feldman has done a lot of research across the state, has done an ethnography of programs across the state, and typically billable revenue might cover 20 to 30%, maybe on the high end 40% of the cost of these programs. So that really shows that, yes, this is money, it's meaningful, but it's not the be all and end all to sustainability of street medicine. There have to be other resources, whether that's enhanced care management, if that's a realistic option, whether that's city and county funding, whether that's grant funding, foundation funding, philanthropy, whatever resources might be at the disposal of that organization. So that's where we've come to. And I'll speak briefly about our program. I'll try to be brief about that, and then happy to answer questions and hear from you all. Our program actually started back around 2018, so we've been around for about 4 years. And we have expanded to the point where we're actually going out 5 days a week at this point, and have been consistently going out on the streets for the last 4 years, and have been billing for our services that entire time, despite the gray area related to this. We do provide primary care services, inclusive of wound care, medication-assisted treatment on the streets. We also dispense non-controlled medications on the streets. We don't carry around Suboxone with us, for instance, because of safety and legal reasons. We do have the ability to do some labs, but not quite at the level that the folks who just presented were mentioning. That's something we want to expand into. And I'm actually really excited to announce that in the last couple of weeks, we've actually done, to my knowledge, what is the first set of billable street psychiatry visits. So we've actually done formal psychiatry on the streets in San Diego, which means patients can potentially get their meds without ever having to go to a brick and mortar clinic. We haven't officially launched that as a formal program per se, so we're doing it at a very low level, kind of piloting it, kind of testing it out and seeing how it might work. And we're hopeful next year we can expand our street psychiatry program. And I have dreams of being able to do long-acting injectable antipsychotics on the streets, which is done in other communities around the United States. So I will leave it there. That's all I wanted to kind of update you all on, but happy to hear from others, questions, comments, etc. I should have told you what Father Joe's Village is too. We're a large homeless service agency in San Diego. I realized I didn't mention that. Apologies.
Well, thank you so much. I appreciate your presentation. So the next representative for San Diego is Dr. Christian Reimers. He's Chief of Population Health of Family Health Centers of San Diego. And the floor is yours.
Thank you, Andrea. Can you see my screen okay?
You can.
Great. So I'm going to present on behalf of really a lot of people that have made this possible in San Diego. And I think where I come from is from the FQHC perspective. I'm an infectious disease physician, so hepatitis C is also kind of the angle that we take. But I think you'll see through the course of my presentation how much overlap there is with street medicine, and how you can take something that looks like a research project and actually show how it can actually pave the way and lead the way to sustainable street medicine. So we approach this with the idea that we really are not doing a great job of reaching people who inject drugs, especially those who are homeless, in terms of hepatitis C care and services. The background here is that we have spent the last 5 years really developing a pretty, well, I think it's a pretty highly evolved primary care-based Hep C treatment program, initially with support from the CDC, the California Department of Public Health, and then a Gilead Focus grant to pay for testing supplies. But we've grown to the point where we have 11, and every year we graduate more, actually. So we're probably up to about 15 primary care-based hepatitis C treaters across 5 of our clinics, with a really nice ecosystem of support where we have hepatitis C navigators that are medical assistants and very well trained, a transplant hepatologist that supports us with our sicker patients, myself as an ID provider, and then we have a sonographer that's helping with some of the FibroScan workload that we have. And we have 2 mobile FibroScan units that are based in clinics, but also move around the county as far east as El Cajon and as far south as Chula Vista, as well as a stationary shearwave elastography unit. And we also, on the other hand, have a longstanding community trust that's been built from operating the only syringe exchange program in the city of San Diego since 2001. I'm happy to report that we've had a recent change in the county regulations where we have lifted the county-wide ban in San Diego of syringe exchange, thanks to our Board of Supervisors that voted on this last year. But in our one that's been operating in the city under special provisions, we've offered clean syringe exchange, Narcan distribution, and referrals to mental health and medical care, as well as housing. But of course, the big gap here is that we've been treating a lot of people in clinic, but really have observed a large unmet need amongst a specific population, which are those who are unhoused and using drugs. So what we did is mapped out really the care pathway traditionally, that what we had been doing, and it really is kind of painful when you put it all on paper to see how many visits it takes to get to actually that prescription. The way we had it set up, and Jeff mentioned this, that we actually, we don't mind seeing patients frequently because we get paid per visit, and we are incentivized, in fact, to do something that's not very client-centered and space things out. But really, being honest with ourselves, it was taking us 4 to 5 visits to actually get somebody started on therapy, and then of course 3 or 4 follow-up visits. And we also know that adjacent to our care and provision of care for hepatitis C are very important other principles. So assessing for medication-assisted treatment, discussing harm reduction, addressing wound care, linking to syringe services programs in those patients it was appropriate for. And then of course the navigation component is absolutely essential. But we basically brainstormed and thought, how can we do this in a more simplified way? It's kind of the trend in hepatitis C is simplify, simplify, simplify. And we came to the conclusion that we could really do the entire workup, or the first 4 visits, essentially with a single visit, where we do a rapid antibody test. We draw blood and do the RNA, as well as the additional testing that's required, really the minimal required, which you see there. If we have a mobile fiber scan, we could do that on site, and then hopefully within a week have treatment available for the client, follow them up, and then assess cure as we normally would. So we developed this research question, which is really to determine the effectiveness of a simplified approach compared with traditional approach, to be delivered in a mobile unit, street side, to try to increase the number of patients who initiate treatment compared to usual care. This was funded by an investigator-sponsored initiative through Gilead, and we designed this as a pragmatic randomized comparative effectiveness trial. And by doing so, really, we're able to avoid some of the really formal and cumbersome consenting, because we were going to treat everybody eventually. And our goal was to enroll 200 patients, randomize 100 to usual care and 100 to the simplified algorithm. The inclusion criteria and exclusion criteria were very loose, and really we did not want to restrict this to many people. You just had to be above age 18, willing to be treated, and then willing to stay in San Diego for 6 months. Exclusion were those who did not have hepatitis C or a negative HCV RNA, life expectancy less than 6 months, pregnancy, or decompensated cirrhosis or liver cancer. We felt those really needed to be treated in a brick and mortar clinic. And of course, we're looking for the number of people that initiate treatment within 6 months, and then a lot of other secondary outcomes, which I like to call the collateral benefits of taking this approach, which is how many people did we engage in medication-assisted treatment? How many people persisted on MAT? How many people received abscess care or general engagement in primary care? And then also some time measures, like how long did it take to start the DAA therapy and how long did it take to complete? We are combing the data and looking at serious adverse events in terms of hospitalizations or emergency room visits during the study period. So here's the map of what things look like. I'll show you some actual pictures in a bit, but here's the cartoon version. So we typically will have up to 200 clients come in for syringe exchange, and they basically kind of line up and go through, get the syringes and sort of leave. And we thought we could place what we call a caller, who is kind of working the line, talking about HCV testing, the importance of testing for HCV, offering MAT as a low barrier bridge, and then offering people abscess care if they needed it. Those who wanted to be tested, we thought we could do up to 15 tests per night using a rapid test. We actually didn't have to do really formal consents, but basically just do an insurance check and register the patient as a Family Health Center's patient, with the simple statement that if you're Hep C positive, you'll be randomized to either get treatment on the unit or in one of our traditional clinics. And then also educate patients on the availability of abscess care and a Suboxone bridge right then and there. As you all know, these rapid tests take just about 20 minutes, and those who were HCV positive would be immediately randomized and either given an appointment at a clinic to be treated or offered an appointment immediately right there in the MMU. If people turned out to be HCV negative, they were still offered care, whether it's Suboxone bridge or abscess care if they needed it. And here's just a couple of components of the simplified workup with a very rapid history and physical, a fiber scan or a mobile fiber scan right on the unit itself, and then a very simplified pared down set of labs. The Suboxone bridges that we give are essentially a 7-day course of Suboxone. Don't carry the drug on the unit itself, but electronic prescription to a very nearby pharmacy, and then abscess care for treating in the mobile unit as we were able to, or triaging more serious infections to the emergency department. And so here's some of the setup. This is launched right in the middle of COVID, so that's why everybody has all the appropriate PPE there. But essentially, setting up a table to do the rapid testing on the street. And what you can see in the background on the bottom right is actually our syringe exchange unit. And then what we did is just park an additional unit right in front of that. So patients that tested positive or needed a Suboxone visit or MAT care could be registered by the gentleman there in the blue, just like I'm wearing, who is a patient services representative. And these are indeed billable visits for us, and allowed it to be a sustainable thing. And I'll just finish with this is not a completed study by any means, and we have not unblinded anything. I think we all anticipate what we're going to show, which is a much higher linkage to care rate and completion rate for those that were offered treatment directly on the streets. But to date, we've enrolled 155 participants, so very good progress, and we hope very soon we'll reach our goal of 200. We've conducted 74 sessions on Tuesday nights, and actually racked up almost 500 qualified visits. And if you're in a FQHC lingo, that means that these are billable visits, actually. Surprisingly to us, the vast majority of them were for MAT. So 72% of our visits have involved some type of MAT, either follow-up or evaluation or prescription of Suboxone. And this is probably one of the key findings here, is that we've taken, seed pilot research funding and really shown that this can be a sustainable model for our C-suite and our executives to look at and say that they want to do, and they've actually already verbally committed to that. And that's because we have averaged 6 visits per night, or a productivity of 2.1 per hour, which in our lingo is actually something that's acceptable, where we can actually cover the staff time and make this something that we do going forward. So in my view, the study is not even over yet, but we've already demonstrated that a focused approach to street medicine involving hepatitis C care, medication-assisted treatment, and abscess care can be a financially sustainable mobile medical unit model of care. We've also had some other great collateral benefits. We have an incredible pool of 8 providers now that have gotten cross-disciplinary exposure and training to treating hepatitis C in primary care, to doing mobile liver FibroScan, and then also becoming very well practiced experts in medication-assisted treatment. We've really provided, I think, a trusted community-based response to the immense need to low barrier MAT, which we've seen with that almost 3/4 of the visits having some type of MAT involved. And then finally, this is how you sort of get things started. We use strategic deployment of research funding to support a pilot project that has now led to addressing a clinical need, and as I mentioned, will be sustained going forward. Very big thank you to the village of people that it takes to put something like this on, and I'm happy to stop here and take any questions.
All right, thank you so much for that presentation, Dr. Reimers. For the representation of payment issue topics, I have George Scolari with the GS Solutions. Until recently, he worked for Medi-Cal Managed Care Plans for 25 years. We'll go ahead and give you the floor.
Thank you, and thanks for the honor of wrapping things up, and I'll be relatively brief. I think there's probably a lot of questions. I know I might have a few myself. So again, I'm George Scolari. I recently moved on from working for one of our local Medi-Cal Managed Care Plans. And of course, when I say Medi-Cal, that's California's Medicaid. So I will keep saying Medi-Cal, knowing you guys all know what I'm talking about. So I did spend 25 years there. 5 years prior to that, I worked for a very large federally qualified health center, but even then it was under contract with that same health plan overseeing their behavioral health services. And about 10 years ago, I started overseeing a lot of the long-term supports and services and homeless activities within that health plan beyond the behavioral health stuff. In San Diego County, our Medi-Cal system is a little bit different. Sacramento and San Diego have a different model than a lot of models in California. Either way, most Medi-Cal beneficiaries in California are in one of the Medi-Cal Managed Care Plans throughout our state. In San Diego, we have 7 of those health plans, and those health plans operate under a really cool umbrella called Healthy San Diego. Some of my partners from Healthy San Diego are on the phone, and nice to see you guys. And I miss you all very much. It's only been 2.5 months since I left after 30 years working with everybody. So it's really a pleasure to be here today. So what's new in California is that has been referred to quite a bit today as CalAIM. So CalAIM stands for California's Advancing and Innovating Medi-Cal. It started a number of years ago, but really kicked off the ground about 2 years ago in San Diego under our Healthy San Diego Collaborative. We did a kickoff event. We do a lot of kickoff events together, the 7 health plans and our buddies at our county's Health and Human Service Agency, our homeless providers, mental health providers, substance use providers. We come together a lot, hospitals, the bit. So we did our kickoff. CalAIM is really about reinventing Medi-Cal, the way Medi-Cal services are delivered. It's giving health plans the opportunity to pay for things that aren't necessarily Medi-Cal benefits. So there's a lot of components to CalAIM. The 2 key components are under the health plan side, because there's other things under CalAIM that are not under the Medi-Cal managed care plans that the counties are doing. But I'm just going to speak to the Medi-Cal managed care plan piece. Those 2 things are enhanced care management, ECM, and community supports. Enhanced care management is where the health plans will contract with primarily federally qualified health centers, but also a lot of our homeless providers and other agencies that have expertise, where they build teams around a single person who is at home homeless or at risk of being homeless, and who's often using the emergency room for primary care and spending a lot of time in custodial care under skilled nursing, things like that. And so we take those teams and through our contracted providers and really work hard to get them off the street. And the goal is to get them permanently housed. And we've shown great success in California under 2 different programs. One was what was called the Whole Person Wellness Program. In San Diego, we called it Whole Person Care, or it was Whole Person Care. We called it Whole Person Wellness in San Diego. And then there was a Health Homes program that both of those programs ended in January 2022 when enhanced care management and community support started. So we take these teams and we can go out there through a group of providers and wrap our arms around one person. And I believe that this is why the governor vetoed this, which is, since the health plans are already paying for these teams, that the street medicine easily can be embedded into that. So I definitely see that payment, any barriers there are to payment are going to go away in California. And it's been mentioned by Dr. Rainers and Dr. Norris, that's already started anyways. A lot of these services are billable, and they should be. I'm a big believer in it, and I'm on Father Joe's advisory board, and I've been watching what they've been doing for a long time. The other component is community supports. Community supports is 14 different predetermined services by the state of California that health plans can start paying for. I think this will be a big help for these street medicine teams. An example of those community supports is a health plan can pay for things that are not Medi-Cal benefits if they can prove they're saving money from a Medi-Cal benefit. And the best sample of that would be recuperative care. One of the best, easiest for me to understand, being a behavioral health guy primarily, is recuperative care typically isn't a covered Medi-Cal benefit, or hasn't been up until now, but a Medi-Cal managed care plan under community supports under the CalAIM umbrella can now start covering recuperative care, because you're saving money that would be a Medi-Cal benefit, like an inappropriate emergency room visit or long-term stay in skilled nursing, because there's nowhere else to go. So we've got, I believe, 3 recuperative care agencies in San Diego, and the health plans are all starting to contract and get partnered with them. And I'm consulting with one of them as we speak, actually. Another service we're able to do is give housing monies up front, deposits, and a lot of other services. So I really think in San Diego and in California in general, you're going to see a big shift to more and more street medicine easily will be covered under the CalAIM umbrella. I know one of my plan partners that I know is on the line right now, and they know I don't like to call out a plan, but I know they've already done some given some grant money and have already started doing some of this in San Diego for up to 200 clients. And it's just the beginning, and they're doing it in some of their other counties. I think that's really, really cool. The health plans are under CalAIM are given quite a bit of money right now to do different things, especially investing in the community they serve. And this would be a good place to put some of those initial monies while all these other payment things are being worked out. I think a barrier to this is, and I learned this from Dr. Norris at one of his advisory board meetings, is when they're out there on the streets and they come across somebody who just won't even give them their name, but they need some help and they're going to provide that service, and how they're going to bill for something like that when you can't even identify the beneficiary at the moment is going to be a challenge for them, and that should be addressed too, because they still need to be paid for the hard work they do. And with that, I think I will leave it and turn it back to our hosts, and so that we can open up to questions. And thank you, everybody. And nice seeing so many of you again.
Thank you so much, George, for your conversation in this topic. And I would like to go ahead and turn it over to Ryan Clary, who will begin opening the floor for questions.
Absolutely. Hi, everyone. I'm Ryan Clary. I am a consultant working with the Liver Coalition of San Diego, and with all of the great advocates in San Diego working toward hepatitis C elimination. Before we get into questions, I'm just going to speak briefly, and feel free to type your questions into the chat. We were asked to just speak briefly around a program called HepNet, which is run by MBHR, NASDAD, and APCHO, our national partners. This is a network of public health, community organizations, advocates, people with lived experience, trying to identify and share best practices and strategies to address the unmet needs of people who use drugs. We'll drop the links to HepNet into the chat and encourage you to look to seek out more information and potentially join. So there's one question in the chat, and then I saw Lori with her hand up. Dr. Reimers, you had a question, or there's a question for you, how your patients handle Suboxone pickup if they don't have ID.
Thanks for the question. I was in the middle of typing an answer in the chat. That's okay. So, we are not dispensing Suboxone out of the unit. So the DEA actually has a higher level of standard if you're carrying the drug with you and dispensing it. That higher standard probably does apply to the pharmacy pickup of that medication, since it's a controlled medication as well. So we just need name, date of birth, and phone number to register for medical care. But it's more of a question for the State Board of Pharmacy, what they are able to dispense in somebody without an ID, and I don't know the answer to that.
That's great. I also just want to say before I call on Lori, if we run over time and we can't get to all the questions, please post them to the chat or get them to Scott or anyone within Hep C San Diego, and we will get the answers to you via email. Lori.
Alrighty, I am in motion and just want to throw out this quick question. So we just completed a community readiness assessment in Southern California, to tell you the truth, but the navigator can't tell where I am. Okay, so let's see. The question is, we just did a community readiness assessment, and a gap in our service delivery system is in behavioral health. They can't bill for harm reduction services. Although I work in the HIV world, and for CDC, we can do harm reduction services. So because there's people and experts, and I think street health might be a link here that we haven't thought of yet. My question is, with all the changes in Medi-Cal, and if harm reduction is going to be something that can, under that community services covered through our County of San Diego behavioral health activities. Whoever wants to take that, go for it.
Any takers? Dr. Reimers, Dr. Norris?
This is George. For 25 years, I chaired our San Diego County Behavioral Health Subcommittee and did a whole lot of trainings on this subject, basically, and just for folks out of California to know, and other states are like this too, is especially mental health and substance abuse services. We call in California the Drug Medi-Cal Organized Delivery System. Those are services that are carved out of Medi-Cal Managed Care. So harm reduction, even MAT, though health plans pay for MAT in primary care and will likely pay for MAT on the street too, because we look at that as primary care and it'll make it easier for our providers. Hopefully Dr. Reimers likes that, but we do cover things even when we shouldn't. But, those types of services would need to be directed to our county's Drug Medi-Cal Organized Delivery System. And I know they are constantly looking at growing and ways to improve. They do an outstanding job. You know, but nobody from there is actually on this call right now.
Okay, thanks. It was really the leadership in behavioral health services in our community readiness assessment to assess if we could start doing certain service programs and where and how and what people are thinking about it that identified it as a gap. So that's the leadership in behavioral health.
Yeah, you're exactly right.
Let's go to Scott, and then we have a question through the chat.
I have a question for Thaddeus and Heather. What advice would you give advocates from kind of if they're looking at their state, how to take best practices to convince their local leadership? How did you do it for Hawaii or Dr. Reimers for San Diego? How can we leverage the learning, and does that work? And how does it get applied?
This is Heather. So one thing that we did is that we did show emergency room utilization. We were lucky to be able to work with our local hospital and be able to show return on investment and how much we could save our main hospital by providing these services in the street until versus waiting until they became urgent to go to the emergency room. And I'm sure that you all see the very same thing. That was probably the most effective that we have. And then secondarily, I think trying to get the wraparound services, because we all know that most of us can't survive even on Medicaid reimbursement because it's still lower than the commercial plans. And so trying to up those rates. I don't know if Thaddeus, if you had anything to add.
Yeah, I'll just add, you know, just that long, someone had mentioned earlier, but just that investment in relationship, I think is really why we were able to do a lot of what we do. We've been around for 11 years in terms of our coalition. So I just think that that time investment in building these relationships is really, really important, at least for us in Hawaii, which is a really small state.
Excellent, thank you. I'll ask one question that went through the chat, and then we will close. So if you have any other questions, just post them. We will also get the questions that were emailed in advance in response to Scott reaching out, and we'll get those answered for you. So this is for Dr. Norris. Dr. Reimers, can you speak to how street medicine teams can meet the requirements of facility site reviews?
So I can start. You know, we've been, as I said in the chat, we've been operating for many years doing primary care out of the mobile unit. So they already are considered sites of care. It gets a little bit different, and maybe Jeff can speak to this if he's still on, about getting outside of the unit and being really on foot in terms of how they're going to respond to those facility reviews. But my impression is that the current regulatory requirements are already being met. And so we're just going to keep doing what we're doing. And I don't see if Jeff is still on.
Okay, well, we are a minute after the hour. Thaddeus has put his email address into the chat if you have any follow-up questions for Thaddeus. So thank you, everyone who came on and shared your expertise and knowledge. Very, very helpful and really timely. With that, I will close our exchange. We will have other exchanges in the future where we kind of dive in deep on an issue that relates to eliminating hepatitis C locally and nationally. So if you have any ideas for future topics, please get in touch with us and let us know. And have a great rest of the day, everyone.
Thank you, everybody. Take care.